So our first case here is one of SVC syndrome. Let's see, there is a great deal of density in the mediastinum, and the SVC narrows down to just a tiny little dot there. But this is the thing that's so striking, is you get these hepatic perfusion changes. This is known as the hot quadrate sign. And so you can appreciate in the subcutaneous tissues there that there are large collateral vessels, and they ultimately go through transpleural collaterals. There goes that SVC. And they fill the liver retrograde. That's all coming from the systemic venous supply. And it goes retrograde through the hepatic parenchyma and into the hepatic veins, and thus back to the heart. So it's an interesting collateral pathway. And you will see this every once in a while when you just get an abdomen pelvis scan. Right? And people, I've seen all kinds of stuff suggested for these liver lesions, and all that is a collateral pathway. And the thing you really need to do is scan the chest when you see this on an ab pel. You can see the umbilical vein there, right there. So coming through there as well. All right, so that's the hot quadrate sign, SVC syndrome. All right, this one's pretty straightforward. This is a 100-pointer in my board review Jeopardy game. But a lobulated density like that should already have you thinking that this is a pulmonary AVM. And in this case, we've got a couple of large feeding and draining vessels. So it really makes the diagnosis. One of those, the top one is coming from the pulmonary artery, and that lower one goes into a pulmonary vein. So remember, when you get multiple ones, you start thinking about liver disease and, of course, Osler-Weber-Landau, which is relatively rare. But these can be multiple, and in patients with liver disease, they can result in significant shunting to the point of actually causing low oxygen saturation, because obviously the blood going through these is not getting properly oxygenated. The other thing that's interesting about pulmonary AVMs is the kind of antibacterial function of the pulmonary capillary bed. And so you lose that, obviously, with this blood just shunting straight through the pulmonary circulation. And these patients are at risk for brain abscesses and other kind of systemic embolic phenomena. So that's a pulmonary AVM. All right, this is quite a case. So this was actually, the thing that was interesting about this is you may know, as a teleradiology practice, we run a lot of artificial intelligence algorithms. We're very smart about the algorithms we chose to build, and they've all been chosen on one of two things, basically: medical malpractice risk, right? The cost of missing a given finding, and our quality assurance data that shows us what are the most commonly missed things that we see. So the two most commonly missed things that we see, and we read a lot of emergency and a lot of CT, are intracranial hemorrhage and pulmonary embolism. So this was one of the first algorithms that we built, and this was one of the first cases that was caught by an AI algorithm. So you can see there's a filling defect here in the pulmonary artery. But in addition, we've got dense consolidation of the left lower lobe. And the bronchus leading to the left lower lobe, you can see right there, is pinched off. It's compressed, and it's actually due to some adjacent necrotic adenopathy. See, on either side, and there's a little hypodensity in each of those nodes, and they are pressing on the left lower lobe the left lower lobe bronchus and causing that airless atelectasis. In addition, we've got a bunch of liver lesions, hypodense liver lesions with vague peripheral contrast, pretty consistent with a MET. And if that weren't enough, look at that thickened adrenal gland and adjacent large left renal mass. Right, so putting it all together, this is a renal cell carcinoma that is venous invasive, right? And remember your three abdominal tumors that do that: adrenocortical carcinoma, hepatocellular carcinoma, and renal cell carcinoma. These are the ones that just love to invade the adjacent vessels. And it's really important that you note the enhancement pattern. As one of my old attendings used to say, that right there is a piece of beefsteak. It's sometimes hard to tell bland thrombus from actual tumor mass, but that is actual enhancing tumor mass. And you can see it is both more heterogeneous and slightly more enhancing than the normal blood that's present in the left renal vein there. So of course, this patient is at risk for PE, and this is something you'll see, right? An angioinvasive renal cell carcinoma presenting initially with pulmonary embolism. All right, so here are the PEs, and if you look at the extent of involvement in that right lung, essentially there's no normal perfusion going to any lobe of the right lung. And then you've got atelectasis of the left lower lobe to the point where that's clearly non-functional, right? Non-ventilated, perhaps perfused, but non-ventilated. So this patient has actually got normal ventilation perfusion in one lobe of his 5, right? The left upper lobe is the only thing that's getting both ventilation and perfusion. So a hyper-emergent version of pulmonary embolism here. Okay, so there again were the filling defects. And let's look at that left lower lobe bronchus that's squeezed there by the adenopathy. There's a little bit of air bronchogram there, but that's not the kind of thing that should dissuade you. There almost always is some residual. Complete absence of air bronchograms in my book is pretty rare. So airless lung is what I prefer to call that. Rather than a lack of air bronchograms, because that's really not the definitive sign. Clearly, that is an obstructed bronchus in spite of the fact that there's a little gas still. All right, so that is a angioinvasive renal cell carcinoma presenting with pulmonary embolism. You know, the involvement of the adjacent, that's probably direct growth into the adrenal gland. And the involvement of the adjacent adrenal gland is very common. That's why, in fact, they used to call these the hypernephroma. That's the old name for renal cell. And it's because they basically thought it could be of adrenal origin. All right, next, an ASD with Eisenmenger syndrome. And it is Eisenmenger. I have to look it up with some regularity, but everybody always says Eisenmenger, and it's Eisenmenger. So there's a little filling defect here. I might have tried to write that off as some kind of artifact. It's in a slightly unusual position, but it is wrapping a bend at a branch point. And so that actually turns out to be a pulmonary embolism. Here it's more definitive in one of the branches of the right lower lobe pulmonary artery. But here's the important finding. There is an atrial septal defect, and note the contrast. You have just enough difference in the contrast between the right and left sides of the heart to be able to say that there is shunting going from right to left. And of course, that's not the normal direction, right? Typically, if you have an ASD, it's going to go from the higher pressure left atrium into the lower pressure right atrium. So, and you can see that that's actually what's been going on for most of this patient's life. The right heart is significantly enlarged, right? So this patient had an ASD with left to right shunting, went on for years like that with the high flow state causing enlargement of the right side of the heart. However, once he had a pulmonary embolism, that raised the pulmonary pressures until they were higher than the systemic arterial pressures and caused the right side to shunt to the left. Okay, and that is Eisenmenger syndrome. So that was something I always struggled with. I never understood the mechanics of paradoxical embolism. It's kind of like thinking back to your childhood. I don't even know what I thought was happening. But this is the typical situation for someone to get a paradoxical embolism, because now with that right to left shunting going on, if there is more clot in this patient's pelvis or lower extremity, it's going to pass from the right side of the heart to the left and give this patient a stroke or an infarct. All right, so that is an ASD with Eisenmenger. And here is a VSD. This one was a crazy case. This is an elderly female. She was in her late 70s, maybe early 80s. And so look at the enlargement of those pulmonary arteries. It's intense. There's peripheral calcification of the PA, which is a sign of chronic extreme pulmonary hypertension. And there is that thickening, chronic looking, really it's organized thrombus lining both of the pulmonary arteries. And that right pulmonary artery, you can see that beautifully there. Right, so that is really long-standing, very extreme chronic pulmonary hypertension. All right, so we go a little lower, and there actually are pulmonary emboli. The one in the left lower lobe is the one I call your attention to. That one looks acute, right? It's sitting in the center of the vessel instead of adherent to the side, whereas that's chronic thrombus organizing there in the bottom of that very large right pulmonary artery. So this is someone with chronic severe pulmonary hypertension, but who has had an acute pulmonary embolism. And here, you just marvel sometimes at the timing that was required. You got to find an old patient who's had a VSD all her life and then nail it with the contrast on the right side of the heart. It's pretty incredible that this all came together. So you can see that the right atrium is enormous. The right ventricle is incredibly hypertrophied. And there is a VSD right there in the membranous portion of the septum, right below the level of the aortic valve, with right to left shunting occurring. So there's that right heart and the VSD. So look at the size of those pulmonary arteries. Again, peripheral calcification of the pulmonary arterial wall, and then an acute thrombus as well, causing right to left shunting. It's interesting, with a VSD, you definitely will get hypertrophy of the right ventricle, but one of my old attendings used to say, with VSDs, you don't get that much right ventricular enlargement, chamber enlargement. And you can see that's the case here. I mean, it's a little large, but it's actually, I don't think, as enlarged as the case we just saw earlier. And the reason is apparently that the right ventricle doesn't suffer from volume overload as much, and it's the volume overload as opposed to pressure overload, right, that leads to chamber enlargement. And the reason it isn't subjected to so much volume overload is it decompresses right out that VSD with every contraction, whereas that's not available to it in the case of an ASD. So with ASDs, you'll get enlargement of the right ventricle. With VSDs, you'll get hypertrophy, but not as much enlargement. And you can see the one other thing that's worth noting here is that there is definite hepatic venous reflux. With a giant right atrium like that, you will frequently see that. All right, so that is a VSD with Eisenmenger. Couple of paradoxical embolism cases. It looks like a stick man sitting in the aortic arch there, doesn't it? I was going to name it for that. That actually is extending up into the left subclavian as well. And you can see filling defects in the pulmonary arteries. Okay, so this is the situation that I had previously described. You've got a patient with an ASD, and honestly, it's not really visible. There's a little streak of contrast in there, and I've been back and forth on this thing. I don't think you can actually see the ASD in this patient, but there is right heart enlargement suggesting it's present. Oh, there we go. So it's running awfully slow. So you can see that clot actually was extending up into the left subclavian. Big clot burden, the main pulmonary arteries, and then right heart enlargement suggesting the chronic presence of an ASD. All right, so that is a case of paradoxical embolism. When you see pulmonary emboli, but also aortic clot, the presence of an ASD can be assumed, especially in the presence of right heart enlargement. So it's pretty rare to see an actual paradoxical embolism worming its way through the atrial septal defect, but this one has it. So again, we've got a filling defect in the pulmonary artery consistent with an acute pulmonary embolism. And in here we have, look, there is a linear plot, and you can see it on both sides of the septal defect. It actually got closed in a slamming door, it looks like. So it's pinned there, half in the right atrium and half in the left atrium. Pretty incredible. And you'll really be able to appreciate that those are contiguous. Right there. Wow. The timing required for this thing to have happened is amazing for us to get this scan. I always say I want to die on a scanner for all that people have done for me with these beautiful images. I'd make a good scan too, not a lot of fat. All right, so there is a paradoxical embolism. Pretty cool. I don't think I would say that that patient's right heart is as large as the previous ones. And you know, a lot of these ASDs can be intermittent. A lot of times they're, when there's an appropriate pressure differential, they remain relatively closed.